Afternoon or evening, wherever you are, and thank you for joining us for this discussion on the healthcare situation in Gaza now and looking to the post-conflict recovery. This aspect is not out front in the news agenda at the moment, especially given the events over the weekend, but the public health catastrophe in Gaza is no less real than before the focus of many shifted to the threat of regional escalation of the conflict, away from the scale of civilian casualties, the dearth of medical supplies, bombing of hospitals and attacks on aid workers, devastation of the health service infrastructure, and as forecasted a while ago, starvation. There's clearly much to discuss here. Joining us today are three distinguished panelists. First, we will hear from Dr. Adil Sakabeikov, the World Health Organization Health Emergency Team Lead in the occupied Palestinian territory, who joins us from Jerusalem. Then we will hear from Dr. Rebecca Inglis, an intensive care doctor and member of the UK Emergency Response Team, who has previously worked for MSF and co-founded a social media platform that shares testimonies from medics in Gaza. Followed by Dr. Gazan Abu Sitta, a British Palestinian plastic and reconstructive surgeon who worked at Gaza's largest hospital, Al-Shifa Hospital, during the outset of the current war and has worked as a war surgeon in numerous conflict zones. After a bit of moderated discussion, we would be delighted to take questions from you. But first, some housekeeping. This webinar is being held on the record and is being live streamed, and a recording will be available to watch online after the event. Please do submit questions to the speakers using the Q&A function on Zoom. That's about it. I think we can start. I'd like to start with Dr. Sakabeikov. Dr. Sakabeikov, if you could start us off by orienting us to what state the Gaza healthcare system is in 6 months into the conflict. Actually, for a bit of context, where did we start before the conflict? What has it come to now? And what are the most pressing issues at the moment?
Thank you so much. Good afternoon, colleagues, and good afternoon, dear audience. WHO is delighted to be part of this webinar. Let me start with where the Gaza's health system was before the conflict on the 7th of October. Prior to the escalation of hostilities in October, the health outcomes in Gaza Strip were particularly on par with its regional neighbors in the Eastern Mediterranean region. Under 5 mortality was around 13.54 per 1,000 live births, and the neonatal mortality was around 7.1 for 1,000 live births. The vaccination coverage for key childhood diseases was quite high, over 95%, which is a very rare in this Middle Eastern country. And as I said, it's even better than the neighbors in the region. What has happened since the October 7th? We have more than 33,000 people who have been counted to be killed, mostly women and children. More than 75,000 people have been injured, and we don't know the whereabouts of around 8,000 to 9,000 people who are still missing, perhaps missing under the rubble. There is also, as you said, there is a serious risk of famine and disease. There is desperation everywhere. I just came out of Gaza last week, last Monday, and there is desperation and there is scarcity of everything everywhere. And there is also a visible breakdown of the law and order. Internally displaced people from the north, from the middle area, are scattered in the southern part of Gaza, particularly in the small city of Rafah, which normally hosts around between 200,000 to 300,000 people, and now it hosts around 1.8 million people. So you can imagine the situation on the ground, with tents being erected everywhere where it is possible to find a small piece of land for the family to have their small tent and small belongings that they have. Because of the situation on the ground and the lack of water and sanitation, there is a significant increase in the number of communicable diseases among the most vulnerable population, especially children under 5. The routine immunization is disrupted because the public healthcare system is no longer functioning. only 11 out of 36 hospitals that used to exist in Gaza Strip are partially functioning. This is what we say partially functioning, is they're not functioning to their full extent. They provide some basic services depending on the amount of fuel that they may have and the amount of medical supplies, pharmaceuticals and disposables they may have. So the health system is collapsing. There are approximately 9,000 people in Gaza who need to be taken out of Gaza to receive the health services that are currently not available in Gaza. Those included people with a different type of non-communicable diseases, diabetes, different types of cancer, treatment for which was not even available before the conflict, and people were referred to the hospitals in the West Bank, East Jerusalem, and other countries. And that also now is coupled with a significant number of patients who need different type of reconstructive surgery or more complicated surgery for the traumatic injuries that they sustained during the war. The health system of Gaza is not only collapsing, but the health facilities, the hospitals, primary healthcare facilities, ambulances, health workers, patients inside the hospitals are being attacked. So since the beginning of the conflict, we have recorded around 438 attacks on healthcare, which resulted in 722 fatalities and unfortunately more than 900 injuries. So overall, the health system is on its knees in Gaza for the moment. And this is a very unfortunate situation. And that comes on top of the fact that more than 70% of the entire civilian infrastructure in Gaza is not functioning. And as you may know, the health is determined by its social determinants, by the availability of water, food, hygiene services, nutrition services, financial services, the functioning markets and everything. That is not there now in Gaza. So I'll stop here. If you have any more questions, please let me know.
Thank you very much. I do actually have a follow-up question, and one is, we've heard a lot about the difficulty of getting medical aid into the country. What are the main challenges being faced with medical aid, and what is it that is most needed that is not coming? And what is coming and what is not coming that's most needed?
Well, thank you for the question. I visited several health facilities when I was in Gaza since the beginning of the conflict. And the first thing that I hear from the health workers and from the patients and from the internally displaced people who are staying inside the health facility for protection is the peace. They would like a stop to the hostilities so that they can get their health care in a safe manner, and health workers can provide the health services to the wounded, to the people who have different type of diseases also in a safe manner. So when it comes to the bringing of medical supplies and medical items into Gaza, WHO as the lead agency for health coordinates the logistics of health supplies into Gaza for all the partners, including UN agencies. UNRWA, of course, is our biggest partner for health, the international and national NGOs, emergency medical team, including the teams from the United Kingdom, like UK Med and others. So we do bring supplies into Gaza. However, it's not enough. There are only one crossing, the Rafah crossing that comes from the Egyptian side of the border that we are allowed to bring supplies in. There is I'm sure you have heard of the maritime corridor from the Cyprus. However, it has not yet materialized. We welcome every opportunity to bring aid into Gaza, but whatever is brought into Gaza, it's not enough because of the different restrictions that are being posed by the authorities. Like the dual list. For example, the dual list poses significant challenges. Even prior to the conflict, there were a number of items on dual list, and we had difficulties of bringing a simple mobile X-ray machine, leave alone the CT scan or the MRI machine, or more complicated and sophisticated imaging devices, or during the COVID time, even the machines for ventilation were very difficult to bring in. Now, in addition to that, of course, for example, the chlorine is on the dual list. That means that we are not able to bring sufficient amount of medical supplies to make water safer and make sanitation safer. That comes also for the medical supplies that operate from the solar panels, like the batteries. The refrigerator that only operate from the solar panels is also difficult to bring. But even if we are able to bring supplies into Gaza, delivering supplies from where we are, where we have our warehouses in the southern part of Gaza, in Rafah, to the north, to the middle, to Deir el-Balah, to Gaza City, even to Khan Yunis, which is also located closer to the south, is a big challenge because the deconfliction that we are working with the authorities is not working properly. And you all been witness to the attack on the World Central Kitchen convoy that happened at the beginning of April, that because the deconfliction is not working. We submit all the details, and however, there's nothing is guaranteed. We also experience significant challenges waiting to cross into the northern part of Gaza at the Wadi Gaza checkpoint for one reason or another. We bring the convoy there with fuel, with medical supplies, and we can wait for hours until we're given a green light to go to the north and deliver supplies. We are being told where the supplies should go. Like we wanted to use a central warehouse of the Ministry of Health so that they can distribute the supplies to different hospitals. However, we were told that no, this cannot happen. We can only bring supplies to specific hospital X, which we are doing right now. So there are significant challenges, and those are the security challenges as well as logistical challenges, but also some of the challenges that, in my view, can easily be resolved through various negotiations at different level, including the member state to member state. Over.
Thank you. Just to clarify, by dual list, you mean a list of aid supplies that are considered a dual use could be used either for harm or for aid, and those are much more restricted.
That's absolutely correct. It's the use
So,
of equipment, yes.
so what you've described, I just want to ask, how does the situation in Gaza compare with what you've seen in other conflicts? I mean, is this to be expected for this type of conflict? WHO has responded in this way to several conflicts over time, or is there something beyond the norm going on here in Gaza? Is there anything special, or is it this is what it is when there's a conflict?
Thank you for this question. I think it's a very important question. I have been working for the UN for the last 30 years. And before coming to Gaza, I was based in Kiev, in Ukraine, which, as we all know, is unfortunately experiencing a big war and invasion of the Russian Federation. Whatever happening in Gaza right now cannot be compared to anything that I have previously seen in my life. And I've been in conflict situation. I was in Darfur, I was in Afghanistan, I was in Kosovo. Like I said, I was in Yemen. My recent duty station before coming to Palestine was Ukraine. And there's nothing that I can compare my experience of being in the war zone to what I have experienced in Gaza. Since the beginning of the war, I was in Gaza in December, and now recently I just came out of Gaza last week, last Monday, and it's beyond words. The human suffering is just simply beyond words. There's a lot of human suffering. There's a lot of if I may use this term, indignity. I visited the Shifa hospital last week after the forces left the hospital, and what I saw was absolutely horrifying. The first thing that I experienced is a smell. Is a smell that I remember on day one, when I went to the medical school, I entered anatomy theater and I experienced the same smell, the smell of the dead bodies. And that was a horrifying experience for me again. I saw the dead bodies who were unfortunately not buried, but just covered with a blue plastic sheeting, or they were in shallow graves,
Graves.
just marked with a piece of stone or something, and I could see the body parts. getting out of those shallow graves. So the experience for me was something that I have never experienced in my life.
Thank you for sharing that. Because one always wonders, war is war and war is horrific, but is there something beyond going on here? So thank you for giving some perspective on that. Dr. Inglis, I'd like to come to you now. In the last few days, we've had the reports that the forecasted starvation in Gaza is now a reality. What are you hearing about the extent of this, and what are the ramifications of this? Are we expecting a famine? And also, could you clarify for us the difference between famine and starvation? And does this change what the humanitarian response should look like, where we are now with starvation? And has it run as expected, as predicted, faster, slower? Any surprises here? And what does it all mean? What are we to take from the fact that there is starvation?
Thank you, and thank you for inviting me on this afternoon. So I think the first thing to understand, there is a lot of talk about imminent or impending famine. And this really comes back to a technicality about declarations of famine. Right now in Gaza, there is famine level hunger everywhere. Famine level hunger is already widespread. Levels of malnutrition in children, so another thing that we look at when we're looking at famine, have already reached famine levels in the north of Gaza and are rising in the south. The reason that people have yet to formally declare famine in Gaza is because we don't yet know for certain if the rise in deaths, which is the third component that we look at. So when we declare famine, you look at levels of hunger, levels of malnutrition amongst children, and then you look for this rise in deaths. In the middle of a war zone, it's incredibly hard to make the measurements that you need to actually measure this and formally declare it. And so we have the latest Famine Review Committee's report, which, to be honest, is, both in their words and as someone who's been working in malnutrition for a number of years, makes for extremely shocking reading. Both the degree of starvation and the scope and the rate at which this has happened have been really unprecedented. What we know is that this level of starvation translates to virtually all households in Gaza at the moment skipping meals every day. We know that adults are going hungry so that children can eat. When that report came out a month ago, they said that nearly 2/3 of households in the north reported people going for entire days and nights without food for at least 10 out of the previous 30 days. So, these are children being put to bed hungry. This is really immense suffering that is coming out from across Gaza right now. In terms of the ramifications of this level of starvation, I think that they're really widespread. But before I come on to that, I do want to clarify, when we talk about starvation, what this really means in this situation is Israel starving the people of Gaza. This is starvation as a weapon of war. And it's not my words, that's Human Rights Watch have confirmed that is what they believe is going on, and that this is a form of collective punishment being imposed. And it's not just through the destruction of agriculture within Gaza or the holdup of food supplies. All of the limitations that we heard about with the previous speaker being put on food supplies getting to the people is what is really going on with this starvation. In terms of the ramifications, what it means is not only that people are at increased risk of infection and disease right now, they are at increased risk of dying. So children with malnutrition are 11 more times likely to die than a normally nourished child. So anything else, the dire conditions that we were hearing about in some of the camps, they are prone to actually infections related to that. But actually, this period of starvation, this period of inflicted starvation, man-made starvation, is going to have both medium and long-term ramifications for everyone who has been exposed to it. So we know that the first years of a child's life are absolutely crucial for their development. But if they are exposed to this level of starvation, both their physical, their cognitive and emotional development are going to be stunted. And that is going to affect their educational attainment in later life. That is going to affect all of these things. This is not something that is going to be readily reversed in the, coming weeks. This is an injury that has been inflicted on the people of Gaza that will be having long-term sequelae, for generations to come. And I think that's the thing that really needs to be borne in mind. This is a huge scope of starvation, a huge, immense suffering in the here and now. But also, this is something that will have lifelong effects for the people who've been exposed to it, the pregnant women, the elderly people. All of these people are going to be suffering from this for the rest of their lives.
Thank you, Dr. Inglis. Just to follow up on that, what do you think the ramifications are of what you call this inflicted starvation will have ramifications over time for those afflicted with it? But do you think it will have ramifications of the way conflict plays out? Is this, again, similar kind of question, is this often used in this way, and does it say anything about, does it concern us about how it might be used in the future, given its success, or how it's played out? Do you have any thoughts on what it might mean for warfare, or has it always been used?
So I think that starvation as a weapon of war, this is not the first incidence of starvation being used as a weapon of war. It has been used in multiple previous settings. But what has made this so horrendous in this specific situation is really the context in Gaza, in which you have an entirely besieged enclave, in which you can so effectively prevent food access to the population. So I think complete border control combined with the extensive bombing campaign and destruction of the agricultural infrastructure and the ability of the area to actually generate their own food is what has allowed the degree of starvation to be inflicted in this circumstance.
Okay, thank you. That gives so much more perspective to the starvation, famine, hunger situation, and I think there may be a little bit of confusion about it. It seems to be that you're saying that you believe, other than a legal technicality, famine conditions really are most being met at the moment. Okay, thank you. I'm going to move on to our last panelist now. Dr. Abu Sitta, the Al Shifa Hospital has been at the epicenter of the crisis, and you've worked as a war surgeon in numerous conflict zones, from Syria and Yemen, Iraq and Lebanon. How would you describe what's been the experience of healthcare in this conflict in absolute terms and relative to what you've dealt with in previous conflict zones? And have you noticed new challenges you haven't seen before in other settings? And if so, why do you think this situation is different? Or if you think it's typical, why is it typical? And what do we need to learn from what's going on with healthcare in this conflict? Sorry, that's quite a lot to take on.
A lot. So to start with the comparative, it's the difference between a flood and a tsunami. There's water, but that's where the difference ends. The sheer ferocity and the number of the wounded, both in the absolute number and in comparison to the available capacity of the system, very quickly overwhelmed the system. Before the war, Gaza had around 2,500 beds. By the end of the second week, Gaza had 6,000 wounded. Shifa had between 600 to 700 beds. These were filled within the first few weeks of the conflict. And so in terms of the intensity and the complexity of the injuries, what has also been different about this conflict is it came at the end of 16 years of the siege that your first speaker spoke about. In terms of, so when he spoke about the dual use, I remember with MSF, we were running a limb reconstruction unit in a MSF facility in the northern part of Gaza and Jabalia. And it took us 18 months to get a simple X-ray machine for the emergency department. The other issue is the percentage of children as part of the wounded. Very early on, 50% of my operating list were children. And the percentage of those children that will be left with permanent disability, the numbers of those children is astronomical. UNICEF back at the end of 23 said it's 1,000 children with amputations. Now my feeling is it's closer to the 4,000 or 5,000. And we know from the literature that each of these children will need a new prosthetic every 6 months because they outgrow the prostheses. And that there's literature, there's evidence in the literature that they need between 8 and 12 surgeries by the time they become of adult age. And so what you have just in terms of the reconstruction surgery needs, with now 70,000 wounded, something that was much more than the system, had it not been so structurally dismantled, could not have coped with that number. You then take into account what happened from the very beginning with the missile attack on Al-Ahli Hospital, and then the destruction of the 3 pediatric hospitals, and then the PRCS hospital in Al-Quds, and then moving to the Indonesian hospital, and then moving to the south and Nasser hospital. All of this means that literally these medical teams that are going in at the moment hang around waiting for their turn to access one of the 9 operating rooms left in the European hospital. A friend of mine who's a plastic surgeon started operating at 9 o'clock at night because that's when her turn came to access one of these rooms. And so what we have is war injuries that are the most complex traumatic injuries, requiring the most complex, prolonged, multi-stage surgeries on an epidemic level, on a level that you think about when you think about infectious diseases or diarrhea or respiratory diseases. When we looked at the marches of return, which were injuries sustained as a result of sniper injuries, so less complex than this, we found that most of the wounded needed 8 surgeries lasting 2 to 3 years. And so the legacy in terms of the burden of care of reconstructive surgery attempts to limit disability, the requirements of prosthetics and rehabilitation in Gaza. This is a major component of the disease load in Gaza at the moment. Take into account that you've lost over 400 of the doctors, nurses, and paramedics, and 900 have been injured. You also not have just lost hospitals, you've lost the staff in these hospitals. And the rest of the staff are completely denuded, both in terms of mental health, in terms of physical capacity, in terms of the energy, and in terms of the loss of hope. You then create another layer, and this is from a friend of mine who remained in the north operating as an orthopedic surgeon. And he was telling me of the last 6 amputations he did, he believes half of them, had they been able to receive proper medical treatment that was timely, would have been reconstructible limbs. But because they were left to fester, to get infected, to get osteomyelitic, he had to do amputations to save the lives so that they wouldn't get septic. So we look at war injuries now and their sequelae in Gaza as a major burden that increases every day, and half of whom affects children.
Thank you for that. On what has to happen now then in the immediate future to address this disaster? I mean, what?
Well, it goes without saying. It goes without saying we need to stop the war. There's no humanitarianization of genocide. You don't drop food parcels and create a pier and kill people at the same time. So we need a ceasefire, and then we need a quick injection of field hospitals and an rapid increase in capacity to allow the treatment of people and the provision of healthcare. We need, as rapid as possible, a replacement of the water and sewage so that the infectious diseases are controlled. And then we set about rebuilding the health system. Some hospitals can be upgraded and fixed. Others, like Shifa, like the pediatric hospitals in the north, need to be built from scratch. And we need to be able to sort out the social conditions, the overcrowding in the schools, that are the drivers of these infectious diseases. And so all of that needs to be done the minute that there is a ceasefire, and cannot be done in the absence of a ceasefire.
Thank you. I'm going to bring in Dr. Inglis and Dr. Sabikoff on what do you think are the priorities of what has to happen in the immediate future, and then I'd like to ask you all to address the more longer term future. But let's start with, do you agree with that, and what else do you think, and what needs to be the priorities, because there is so much that needs to be done. Can you share with me your thoughts on priorities and the immediate future? Dr. Inglis, you're to my left on the screen.
So I would agree with everything that Dr. Abusita said already, but just to highlight what I think is a real priority at the moment, and that is supporting the medical staff of Gaza. So at the moment, doctors, nurses, other allied healthcare professionals in Gaza are exhausted. The majority have had, especially Ministry of Health staff, have had no salary since October. They have been displaced multiple times. They are living in tents. The cost of feeding their families is huge. So they are suffering all of these same challenges while also trying to get to the hospital every day, finding fuel to get to the hospital every day, and contend with all of these risks. We haven't really dwelt on things like the risk of abduction from their place of work. We've seen a huge number of healthcare workers detained, including while at work. And I've been collecting multiple testimonies of their abuse and descriptions of experiences amounting to torture while in detention. So that is a huge stressor for healthcare workers working there at the moment. But we know that without supporting existing healthcare staff, they're not able to provide good quality care. So particularly addressing the need to pay them. A challenge of field hospitals is that it has a tendency to pull staff away from the Ministry of Health hospitals. There's a current setup whereby the Ministry of Health lets doctors and nurses spend 25 hours a month working for an NGO, and then the rest of the time they work in the MOH hospital. And systems like that, or what the WHO has been suggesting, which is donor support for salaries to stay within the Ministry of Health hospitals, is all an absolutely critical first step, supporting the resources that are already there, supporting the hardworking staff that are on the ground at the moment.
Please do go ahead, Dr.
Yes,
Sabekov.
thank you so much. I would agree with my previous colleagues and previous speakers, Dr. Abusita and Dr. Inglis. One remark from my side. Of course, the peace is the first thing that need to happen. However, if the peace is not there, we need to continue to provide humanitarian assistance because people are still there. People are still suffering from trauma, from malnutrition, from different diseases, and we need to be there where when people need our support. That means that there should be more opening for the aid to come into Gaza. There should be more deconflict. There should be proper functioning deconfliction mechanism when, for example, we together with partners try to revitalize the hospital like it happened with Shifa after the first siege. We try to bring it back. However, it was a second incursion and everything that we invested at that time also was destroyed. So this needs to happen. Then there needs to be more access to health supplies to the health facilities. So we need to be able to bring more pharmaceuticals, disposables, and the stuff that is needed to treat the patients, including food and water to those patients as soon as possible to every health facility. We need to continue to support the primary health care, the vaccination campaigns that Ministry of Health together with other partners like UNICEF and others are doing on the ground. We need to boost up and make sure that the system is not fully collapsing, that there is at least something where the people can come to the health facility, be it a small primary healthcare facility, medical point in the IDP camp, or just a simple corner where people can get basic services such as vaccination, such as wound management, for example, for the injured, such as community management of acute malnutrition, and the management of non-communicable diseases such as diabetes and mental health and psychosocial support. Those things need to happen. Of course, we also need to make sure that we need to advocate for stop of the attacks on healthcare, on the hospitals, on the health staff who sometimes are prevented to come to the hospital because of the activities around the hospital. So they are not able to come to the hospital and to do their job, or they're not able to get out of the hospital to feed their family. My previous speaker was talking about the detention of the healthcare workers while in service. We also witnessed this when we were trying to transfer patients out of Shifa hospital into the more safer zones in the south. And this, of course, must stop because without health workforce, you can bring anything you want, but without people, the health system is not functioning. That also, emergency medical teams, including the foreign emergency medical teams that are currently coming into Gaza, we always encourage them to be attached to the existing hospital. So that I think Dr. Abusita referred to his colleague who had his or her turn in the surgical room at 9 o'clock in the evening. That is exactly what we are also advocating, is not to create an additional health facility and take staff from the MOH facility, but to be embedded in the health facility that is at least partially functioning and use that as a base to provide healthcare to Gazans. Over.
Thank you, Dr. Abusita, and then I will move to audience questions.
So my point about the field hospitals is really related a lot more to the north, where physically there's not enough hospitals that have not been completely demolished. The only fixable hospitals in the north now are Al-Auda Hospital, which is a very small NGO hospital in Jabalia camp, and what's left of the Ahli Baptist Hospital in Gaza City. And so it was more related to that. And I would also like to kind of echo what Dr. English said, that after 2003, Iraq in the following 5 to 10 years lost 3,000 doctors to the collapse of the health system. And it is critical from now to try to retain staff in the Palestinian health system through the support of their salaries. At the end of the day, as she said, people have not been paid since October, and people have run out of their savings, and have had all of their belongings destroyed. They've had their homes destroyed, their private clinics destroyed, their cars, everything that they've had has been destroyed. And therefore, they've become impoverished, yet they still go into work. And so, both in the immediate and as part of the recovery process, we need to figure out a way to help the health staff in Gaza stay and not leave because they need to feed their families.
Rebecca.
Emma, very briefly, just to add on to that, I completely agree, is to think about the training needs of junior doctors and junior nurses. And this is something that the international community can potentially help with. There are a lot of junior doctors who are still needing to complete their training and need support on this going forward. But I'll leave that there for the moment.
Thank you all. That's given us a great start on what needs to be done now. More than a start. I'll come on later towards the end of the webinar on long-term recovery needs and prospects and realistic expectations. But over to the audience questions. The most upvoted question at the moment is from John Paul Rosario, and I will put it together with another question that's very similar. But his question is, what are we looking at in terms of PTSD, particularly with children? I see this as a long-term problem and a serious challenge. And the question that is very similar comes from Mervat Slater. Do you have any info on mental health support? Is there any available for people? And if mental health medication has been admitted into Gaza? Thank you. And also on that PTSD thing, if we could talk about, what care there is available, or how much priority it is, but also the implications of that going forward if it is not dealt with. Thanks. Who would like to take this on?
Dr. I can start.
Okay, go ahead.
Okay, thank you for the question. I think this is a very important question. However, I would like to emphasize that we are not at the end of the war now. So the MHPSS support is definitely a crucial part of the response of many agencies, and WHO as the cluster lead agency for health is of course coordinating all those efforts. When it comes to the medicines, especially the psychotropic medicines that part of the management of mental health is of course they're coming inside Gaza, but the distribution of those medicines into the primary healthcare facilities where they're usually dispersed from is a challenge because of the security, because of the access issues, etc. So I think in that sense, there are medications, but I refer, if you refer to my previous conversation about the challenges of bringing those medicine to people is quite difficult. Also, the other element that I wanted to bring, even before this war, Gaza suffered a great deal of mental health and psychosocial issues with the Great March of Return in 2018, as well as with the Gaza war in 2014. So there's an entire generation of Gazans who have lived from one war to another war, to another war, to another war. They have lost their families, they have lost their loved ones. Children don't go to school, and as we know, school is one of the safe places that can be provided for children to heal their mental health wounds, and still we're still under the bombardment. Still bombs are falling on the heads of the children and the ordinary people in Gaza, and in that situation it's very difficult to address any kind of mental health and psychosocial needs. However, there are some networks inside Gaza, including the civil society organization that work in partnership with UNRWA, with other health providers at the primary healthcare level and at the secondary healthcare level, especially with the providers of the health services, to make sure that at least some sort of psychosocial support is being provided to them. But again, until the war is over, it's very difficult to speak about the comprehensive mental health and psychosocial program. But yes, it is being addressed, and when we will be speaking about longer term recovery or medium term recovery, I'll be addressing that issue. Over.
Go ahead, Rebecca.
A brief addition to that. So I think that there has been a lot of people trying to offer online mental health support to Gaza. I don't think, and friends and colleagues on the ground, this is not the priority at the moment. I think people need to recognize that there are Gaza trained practitioners who are very well placed to offer psychosocial support when the time is right, when they are able to. And I think drawing on them as a primary resource, potentially mapping out their availability within Gaza, is a helpful first step, rather than wanting to go ahead and offer online support.
Okay, thank you. I'm going to go to one that's also upvoted, but I'm not sure that this is really in your three areas of expertise, but I'm sure you might have some thoughts on it. And this is from Adam Coots. Health services should be neutral areas for negotiation, but international humanitarian law has been destroyed in Ukraine, Syria, Iraq, Yemen, and Gaza. How do we fix international humanitarian law? You don't have to give me lawyers' answer, because I know you're not international humanitarian lawyers, international lawyers, but any thoughts on this from your perspective on the ground and in the thick of this? Go ahead, Dr. Abusita.
So what makes this different is because we did nothing in the previous wars that Adam mentioned. And therefore, we came to a war where the destruction of the health system became central to the military strategy. And an integral component of what was the output of the military strategy. And unless there is a successful application of international law in terms of justice against the perpetrators, then we will start the next war where this war ended. And as we started this war, where the previous wars that Adam spoke about ended, we will start with the next war with this concept of really going after the health system and dismantling it as being taught in military academies as the way to conduct war. And so unless we apply International Court of Justice rulings, apply international law, then impunity is what drives these wars. Thank you.
Dr. Inglis, I see you nodding quite a bit. Do you want to add to anything? You don't have to.
Well, I would agree that everything that's been unfolding in the past 6 months sets an absolutely devastating precedent. If we accept, and I think that colleagues in Gaza are absolutely staggered that this is unfolding in the 21st century and people are not taking more decisive action to prevent it, the whole-scale destruction of the healthcare service will become part of military strategy going forward.
Thank you. I'm going to ask a more practical question now. And this one is also one of the most upvoted, and that's Hassan Hadi. What can we do here in the UK to directly aid those in Gaza?
Put pressure on the government to call for a ceasefire. From a purely public health prophylactic measure, you cure war injuries by stopping war.
Dr. Saba Baikoff.
Well, I think Dr. Gazan said it all. I'm not a UK citizen, so I cannot speak for the UK citizens. It's up to the UK citizens to decide how they will speak to their own government. But from the perspective of public health and from the perspective of health system recovery of Palestine, I think we've seen a number of good examples where UK public was present in Gaza as a part of the emergency medical teams operating in different hospitals. There is a UK Med field hospital that is currently in Rafah, and there's we as a WHO, we helped also this UK Med hospital to install itself, and I think this kind of gestures of goodwill and support of individuals to the cause of Gazan people is very much welcomed. To be and to support the health system of Gaza at these difficult times at this very important times for the health system of Palestine. But the rest, as Dr. Gazan mentioned, I think comes to the how the citizens speak to their own government. Over.
Thank you. There's one here from Gillian Dare, who's asking if you can tell us anything about the trauma experienced by medical staff and white helmets, along with their own hunger, etc. Can they continue to serve their people much longer? What is their mental health and morale like? Reports from the ground.
I think from the experience that I have of speaking to colleagues, Palestinian colleagues who are still in Gaza, I think there's a sense of hopelessness. There just does not seem to be an end in sight. A lot of our colleagues have lost family members, and all of them have lost their homes. And so there is not just physical exhaustion, but mental exhaustion, and yet they continue. We need to be able to support them, as my colleagues have said, and we need to be able to bring a quicker an end to this war as possible, so that they can stop. Because the problem is that they will never stop working, even though they are absolutely exhausted mentally and physically, so long as the war continues.
Yes, if I can also give you a small example, when I was in Gaza in December, I visited a small hospital called Patient Friendly Hospital, which is next to Shifa Hospital, and I met a doctor, a surgeon, in fact, from Shifa Hospital. He didn't speak English, I didn't speak Arabic, but at the end we realized that we both speak Russian. And because many doctors in Gaza were studying in Russia or in Ukraine or in former Soviet Union countries, and he gave me a horrific, he brought me actually to his niece's room, and he gave me his horrific account of how he amputated the leg of his own niece in his own kitchen with a kitchen knife. And hearing this in a foreign language is something different for me. But hearing it in the language that is close to my heart is absolutely devastating and horrendous experience I've ever heard in my life. And if that doctor did that in his own house to his own niece with his bare hands, I cannot imagine what other doctors, other health workers went through, especially when they were being bombed and their families are being killed. Our own staff, WHO staff, was unfortunately killed alongside with her 50 extended family members, her brothers, her sisters, her nieces. The only living family members are mother and father. So you can imagine how they feel of losing the entire family. And maybe Dr. Gazan, you know them. This is our colleague, the daughter of Dr. Abdulatif.
Dr. Inglis, you had your hand up, but have you changed your mind?
Well, I was going to say it's pretty hard to follow that, but I think the thing just to convey is the degree of moral injury that colleagues on the ground in Gaza are suffering. We spoke a lot about preventable deaths and preventable disabilities that are happening at the moment because of all of the things that are going on in the destruction of the healthcare system, and to be wanting to deliver a higher level of healthcare than they are currently able is a source of immense moral distress to colleagues on the ground.
Indeed. We're coming, I'm sorry we couldn't get to all the questions, but we're coming to an end, and there is one outstanding question here, and which I promised to give you a chance to speak on before we wrap up. But sorry to ask you to be brief on this, and that is, let's go to the long-term recovery. Given we've had a lot of discussion about how unprecedented the scale of this devastation has been relative to other conflicts. But so, thinking of that, what do you think are going to be the main challenges for the long-term recovery, but also as part of that, and what do you think is going to be realistic in terms of recovery? What can we expect it to look like and over what time period? And a related question to that is obviously highly political is, how well do you think healthcare needs are going to compete with the other demands for the recovery phase? Given the unprecedented nature and the horror of this, do you, I guess, realistically in your heart of hearts, think this is going to compete well? But firstly, just give me the priorities for what has to happen, what's going to be the main challenges for the long-term recovery of the health system, and what is realistic to expect as far as where it can get to over what time period. And lastly, how well do you think it's going to compete out there in the political arena for attention, money, and investment for this? Go ahead.
So immediately, there needs to be an increase in the capacity of the system so that allows the provision of healthcare while those facilities that are partially damaged can be fixed. And then those who are completely damaged, we can start rebuilding them. We've lost people whose training has taken over 10 to 15 years. And so we will need to be able to retrain doctors and nurses in the region, preferably, and abroad. We need to find a solution for the medical schools that have been destroyed, particularly those in their final years and the year before the final years in the hospitals around Palestine, so that we don't lose another 600 doctors because we can't find them places in medical schools. And we need to, in the long-term part of the recovery, restore those infrastructure that affect people's health, water and sewage, housing, nutrition, all of these things. So in terms of competing, I think health will probably be one of the easier ones to fund, but it needs to be done in a structured way, and it needs to be done to treat the biosphere that this war has created, not the biosphere that existed prior to this war, i.e. we need health workers to look after the 70,000. If you look at 70,000 wounded and you think each one of them needs one change of dressing a week, there's no amount of care that you can provide. So we need a health system that is designed for the biosphere of the Gaza war, not the biosphere of the Gaza siege.
Thank you. That's a great way. Unless Dr. Inglis and Dr. Sababaikov, you're dying to add anything to that, we are at time. So if it's okay with you, I'd like to thank you all three, very distinguished experts and practitioners in this area, for sharing your perspective and a very sobering discussion on what is going on and what the prospects for the future are. So thank you all for your participation, and thank you to the audience for some great questions. And again, apologies we couldn't get through all of them. I'd like to remind you that a recording of this will be available online on the Chatham House website, so keep an eye out for upcoming webinars as well in this Israel-Palestine series, which this was a part of. So I thank you all. I've gone 1 minute over, but wishing you all a good rest of the day, evening, afternoon. Thank you.